Our next speaker is Dr. Tracey Wilkinson, who will be speaking about being an effective reproduction health care advocate for your adolescent patients. Dr. Wilkinson is an assistant professor of pediatrics at Indiana University School of Medicine. She completed her general pediatrics fellowship at Boston Medical Center, and while there in fellowship, she began conducting research on access to emergency contraception for adolescents. After completing her fellowship, she was in California for 3 years at Children's Hospital of Los Angeles, where she did clinical work and teaching. She ultimately returned to her research position at Indiana University and is now focusing on work around contraception access for adolescents. Please welcome Dr. Tracey Wilkinson.
Thank you, Dr. Galeotto, for that introduction. I have no disclosures to report for this presentation. The objectives of this presentation are to review adolescent developmental milestones and pregnancy trends, to understand the current status of sex education and access to care, and third, learn how to be an advocate for your patients. So to get started, I first want to define advocacy as, quote, an action by a physician to promote those social, economic, educational, and political changes that ameliorate the suffering and threats to human health and well-being that he or she identifies through their professional work and expertise. Second, I want to take a quick moment and let you know that I am a general pediatrician with no additional training in adolescent medicine. However, I'm giving this presentation because I do research and advocacy around adolescent health, and I truly believe there's a role for all general pediatricians out there to do the same. This presentation is focused on adolescents, and it's important to remember that this is a unique phase of development. They too have developmental milestones that are important to keep in mind when thinking about how they approach decisions around sexual health and contraception. While this presentation focuses on contraception and pregnancy prevention, a lot of this applies to sexually transmitted infections as well. So some of the tasks of adolescents include adjusting to sexually maturing bodies, understanding and expressing more complex emotions, the development of coping skills in decision-making, problem-solving, and conflict resolution, the evolution of autonomy, as well as the transition from concrete to abstract thinking skills. These tasks and developmental milestones are all interrelated and play a part in the development of their personal identity. So collectively, this unique phase of development has some factors that put adolescents at disproportionate risk for pregnancy and sexually transmitted infections. First, as I mentioned in the last slide, one of the important transitions includes the shift from concrete to abstract thinking. Their concrete thinking can inhibit their ability to plan ahead for the need for condoms or contraception, or understand the consequences in the future of their behavior today. Second, adolescents' frontal lobe is particularly sensitive to rewards, to the point that although a risk to a behavior may be known, the reward is still worth more. And third, and finally, there is the personal fable, which is summarized by saying that they are unable to judge their risk for STIs or pregnancy and often look at other people as getting pregnant, not them. They may be in a monogamous relationship, which gives a false sense of security to them, but we know that it only takes one partner to put them at risk. But they often have no prior experience to modify those beliefs. They had unprotected sex one time, nothing happened, so why would anything happen the next time? And all of this occurs within the backdrop of the sociocultural environment that we live in. So the music they're listening to, the shows that they're watching, the advertisements that they're seeing, and what's trending on Twitter is all contributing to their knowledge base. So it isn't surprising with this transition to adulthood, teenagers are having sex. Although it's rare among young teens, by the time they graduate from high school, a little more than half of men and women report to being sexually active. And you can see by the age of 20, that's closer to 80%. So how does that compare to other countries? The average age of first sexual intercourse in the US is approximately 17 years old, and this age lines up with data from similar countries. This age has also not changed a lot since the 1940s, because this transition is part of human biology and the development of a sexual self. And just like we provide anticipatory guidance around 6 months of age for a baby, because we know that that baby will soon be mobile, our patients deserve anticipatory guidance on this topic as well. Let's take a quick moment to put together some important statistics. I'm going to give you a moment to get the answer to these questions. A teenager having unprotected sex for 1 year has a blank percentage chance of getting pregnant. The answer is 85%. And teenagers, on average, take how many months to present to a clinician to talk about contraception? The answer is 17 months. Despite these facts, in terms of pregnancy, the good news is that we are doing better. Since the 1990s, we have been seeing a general decline in the teen pregnancy rate and a more drastic drop in the last 7 years. But keep in mind that 75% of these teen pregnancies are still unplanned, and 30% end in abortion. And while these declines in teen pregnancy have been very impressive, it's also important to remember that these gains have not been experienced equally. The map focuses on teen birth rates, with darker shades representing higher teen birth rates. And there are states that have birth rates that rival developing countries. Unfortunately, the arena of sex education has been changing and becoming less comprehensive. You can see that over time, the percentage of teens receiving any sex education, including abstinence only or human development, has declined in the last 15 years. When sex education is being taught, and teens are specifically asked what they're learning in class, you can see that fewer teens report learning about birth control methods, and more of them are being taught abstinence-only curriculums. This decline in reported sex education is not surprising when you look at how few states require sex education to occur. Those states highlighted in red are 26 states that do not require sex education to be taught currently. Next, a vast majority of states have legislation that do not require that sex education is medically accurate. And finally, highlighted states on this map require that if sex education is provided, abstinence information must be provided, but information on contraception is not required. The AAP policy statement on sex education supports comprehensive and medically accurate information for all students. And our adolescent health colleagues recently issued a policy statement on abstinence only until marriage programs. They concluded that they were not only ineffective, but also a human rights violation, as they withhold medically accurate information from adolescents. Yes. The importance of confidential care is also clear, as many studies have shown that adolescents will avoid care if they can't be assured of confidentiality. The AAP has policy statements reiterating the importance of confidential care within the realm of electronic medical records and insurance billing. And it's important to remember, when you ask parents about confidential care, a majority support it. A national survey found that 66% of parents agreed that it was important for their teenager to have confidential conversations with their physicians. So pediatricians serve a unique role in seeing adolescents during this critical time of development and exploration. And although we are incredibly grateful for our adolescent medicine colleagues, there simply are not enough of them to go around. And as you can see from these graphs, a majority of adolescents remain in the care of their pediatricians throughout their adolescence. Although pediatricians are in an excellent position to educate their patients about sexuality, that doesn't always happen. A study reviewing health maintenance visits found that 1 in 3 adolescent patients did not receive any information on sexuality from their pediatrician. And another study found that if those conversations did occur, they only lasted 40 seconds. It isn't surprising that reproductive health is not a comfort zone for pediatricians. We only have 1 month out of 36 months of our training dedicated to adolescent medicine, and most of the inpatient morbidity is in children prior to adolescence. While we, as general pediatricians, have not received much formal training, that does not need to be a roadblock. And the rest of my presentation is going to focus on how you can be a reproductive health advocate for your patients. But before I transition on how to be an advocate, I want to take a quick moment to return to the graph depicting teen pregnancy rates over the past 15 years and point out a very important detail. Given the decline in teen pregnancy rates that we have experienced more recently, analysis has been done to determine the etiology of this decline. And it's been shown that this drop is not because adolescents are having less sex. Instead, 97% of this decline has been attributed to better contraception. So where does that leave us pediatricians? We are in a great position to be advocate for our patients in the realm of reproductive health. There are many layers of advocacy that are possible, and I want to take the remaining part of my time to talk about patient-level, local, state, and federal advocacy that any general pediatrician can do. All of these resources that I discuss in the following slides are part of the handout for this presentation for your future reference. So first, to be a patient advocate, you can make it a point to talk confidentially about reproductive health with all your teen patients, regardless of whether you think they are at risk or not. A simple question, such as, have you ever been more than friends with somebody, can help start a conversation. Don't assume sexual orientation and ask, are you attracted to boys, girls, both, or other? Clarify their gender identity by asking, do you identify as a male, female, or something else? And another idea is to make these questions part of a behavior screening questionnaire that's done before a visit. Another important form of patient-level advocacy is to prescribe contraceptives to your patients. Prescribing contraceptives is well within the scope of practice for any general pediatrician, and all contraceptive methods can be started the same day you see a patient. There are a lot of resources to help in terms of learning how to counsel, prescribe, and start contraceptives. The CDC publishes the medical eligibility criteria that you can download and consult as a reference table and can be used in the free phone app as well. There are published algorithms on how to quick start contraception on the same day you see a patient, regardless of the method that they choose that day. There are other apps that enable you to enter your patient characteristics and will give you recommendations of possible contraception right on your mobile device. As a reminder, as of 2014, the AAP contraceptive guidelines have changed and now recommend counseling based on efficacy. So that means talking about long-acting reversible forms of contraception like IUDs and the implant first, which requires a practice change for a lot of primary care doctors. It's also important to take a quick pause and remember that providing information about safe sex has never been shown to result in an earlier age of first intercourse, increased rates of sexual activity, or greater numbers of partners. Second, you can make sure that your patients have access to services or providers that they may need. If you can't or don't offer reproductive health care, make sure your patients can get to a provider that does promptly. But also remember that a referral is not enough. There are a lot of barriers that adolescents can face, such as transportation, a referral not being approved, or a prescription that isn't covered. So by assuring that they get to the next step is a form of advocacy. And also, remember to provide a bridge contraceptive that day until they get to that next provider. For example, you can give an oral contraceptive until they can get an IUD placed. As a general pediatrician, you can get training to provide long-acting reversible contraception. The company that makes the arm implant, Nexplanon, provides free, in-person training, and you can go to their website to sign up. This form of contraception lasts 3 years and requires no additional equipment in your office other than the device itself. You can also obtain training in IUD placement by teaming up with other providers in your community that already provide these services. Another piece of patient-level advocacy is knowing your local resources. Get to know a few other clinicians that can serve not only as information sources when you have a question, but also as a referral source for your own practice. Seek out other colleagues in family medicine and OBGYN that are adolescent-friendly. For example, if you can't provide an IUD or Nexplanon, know who in your community does provide those services. You can find Title X clinics which offer confidential services to adolescents via a zip code locator on the Office of Population Affairs website. Planned Parenthood also has a similar location locator based on zip code, and in certain states provides telemedicine on their website. Websites such as bedsider.org and the Association for Reproductive Health Professionals can also help you find local providers of reproductive health by zip code. Another important form of local advocacy is assuring that you create an environment that enables delivering this care within your own clinic. The CDC publishes this infographic on how to deliver teen-friendly reproductive health care that gives a step-by-step approach on how that can work in an outpatient setting. You can familiarize yourself with state-specific laws around consent and make sure that your clinic staff knows all of these laws, since they may be the first people interacting with adolescents presenting for care. You can adopt clinic policies that make confidential care standard practice and ensure that your electronic medical record also ensures confidentiality. Local advocacy is also important and something that is important for your own community. As a pediatrician, it is vital to advocate for comprehensive sex education. And from my previous slides on sex education, there's a lot of work to be done. This can be done by serving on local school boards and parent-teacher associations, or just speaking at a meeting about the importance of this education to be a part of all curriculums. You can also write letters to your local papers on issues that affect patients. This is an example of a letter I authored to our local paper about abortion legislation that would directly affect our patient population and their families. And aligning with local advocacy groups is another way to get involved with issues that are happening locally. In terms of state-level advocacy, there are often bills proposed that affect the arena of reproductive health. In fact, in the first 6 months of this year alone, 49 states and the District of Columbia have already introduced 581 pieces of proactive legislation to advance access to reproductive and sexual health care. And here are some examples from a few states. 202 of these bills have passed at least one committee and in a state legislature, and 56 of them have already been fully enacted. Another form of state-level advocacy is joining your local AAP state chapter, as they're often aware of state-specific issues and policies coming down the pipeline and can help you connect with local organizations working on specific topics within your own state. For example, I was asked to testify against a mandatory parental reporting bill in Indiana from the perspective of a pediatrician and how important confidential care is to our patients. Although that legislation ultimately passed in Indiana, When a case was filed to appeal this in a federal court, I was asked to submit an affidavit in that lawsuit, and that's currently stopped that law from going into effect. Thank you. So finally, there's national level advocacy, which can involve meeting with your congressional representatives. Use the AAP policy statements when you talk to members of Congress, because they're not only your opinion, they've been endorsed by the largest group of pediatricians in this country. Topics to discuss include comprehensive, evidence-based, and gender-inclusive sex education, as well as access to care and avoiding legislation that interferes with the doctor-patient relationship. Advocacy organizations, including the AAP, help make advocacy easy. You can log on to the AAP Advocacy Center and send pre-written emails to your representatives on current issues that involve a 1 to 2 minute time commitment from you when Congress needs to hear from physicians. In addition to the AAP, you can join some of AAP partner organizations in national advocacy. Organizations such as Physicians for Reproductive Health, Association of Reproductive Health Professionals, or the Society of Adolescent Health and Medicine. All of these organizations have wonderful listservs that any general pediatrician can join, and that can help link you to a lot of information and opportunities for advocacy as well. Remember that physician voices do matter. The latest round of healthcare reform debate was affected by the opinions of physicians, and the focus on avoiding cuts to Medicaid was a huge point of that debate. Pediatricians talking about what this would mean to child health was imperative, and it will continue to be. However, keep in mind that this debate will continue, and there is always going to be a need for advocacy around assuring access for adolescents and reproductive health care. I'm going to end with a quote from Abraham Jacobi from 1858 that makes the same case about the importance of physician advocacy over 150 years ago that I'm trying to make today. Quote, "It's not enough, however, to work at the individual bedside in the hospital. In the near or dim future, the pediatrician is to sit in and control school boards, health departments, and legislatures. He or she is the legitimate advisor to the judge and jury, and a seat for the physician in the councils of the republic is what the people have a right to demand." Thank you.